Well, welcome everybody to this ISN-ISPD joint webinar on the use of PD for COVID-19-associated acute kidney injury. We're going to go through the clinical aspects of this and also present the updated 2020 ISPD guidelines for the management of AKI with PD. So the UK data, and I'm sure that this is replicated in every country with COVID, is that renal disease or acute kidney injury is extraordinarily common once people are on ventilators in ITUs. So the UK data is that 25% of people are requiring renal replacement therapy, and that this is having a major impact on the supplies that we've got available for CRT, and therefore we are having to think of other ways of managing people on ITUs, and hence the use of PD is becoming extraordinarily popular, as witnessed by the number of people who are attending this webinar. And this was even highlighted in the New York Times on Saturday, and similarly on the 1 o'clock news yesterday here in London, in the UK, that dialysis is becoming limited. So it's not just ventilators, it is also dialysis support. So the outline for this webinar is Brett Cullis from South Africa, who has been involved with saving young lives and is the program chair, is going to be presenting the new guidelines that the ISPD is producing for the use of PD. And hopefully after you've listened to him, you may actually think that in many situations, PD may be preferable to hemofiltration for some patients. We'll then hear some clinical inputs from my colleagues Hugh Cairns and Elaine Bowes at King's College Hospital, where they, as of yesterday when I heard them present their data, London group have tried PD in 34 patients. We're also going to hear about the North American experience by Miran Naljayan from New Orleans, and we'll finish off with 10 minutes worth of questions and discussions. You can type in your questions throughout the webinar. Simon Davis will go through those, group them together, and then put them to the panel. So over to you, Brett.
Okay, thanks very much, Adrina, and thanks to the ISN ISPD for letting me share the ISPD guidelines for treating AKI with PD. And I'm going to talk about its application to treatment of COVID-19 as well. Excuse me while I get my slides forward. So just an outline, I'm going to talk about COVID-19 and AKI. Critical care issues relevant to nephrologists, especially in these patients, and how you might choose your dialysis modality, as well as how you dialyze these patients. Some acute PD fundamentals, the advantages and disadvantages of PD and AKI, and then I'll go through the update of the new ISPD guidelines, what's new in 2020. We're about to submit these for publication, but I'll go through some of the changes from the old guidelines, and then some practical application of these guidelines for COVID-19. Now, we've all seen these slides, and we know that COVID has spread rapidly across the Northern Hemisphere. Thankfully, many of the countries are reaching a plateau in terms of the number of new cases that they're seeing. But there's been a huge number of cases, and these cases are increasing in developing countries. And what we're very concerned about is that in low and low middle-income countries, are they actually going to be able to deal with the lack of resources, especially with PPE equipment and with dialysis equipment, to deal with the number of patients developing acute kidney injury. Now, this first paper up in the left-hand corner suggested that there actually wasn't a problem with acute kidney injury, but Adrina's shown you the UK data, And subsequent papers have shown that actually acute kidney injury is a little bit more common, around 11% in this study from Wuhan. And these are patients admitted to the ICU, showing around 29% of patients have acute kidney injury. And of those patients who died, 25% of them needed renal replacement therapy. And this paper that was published yesterday in JAMA from New York, these were all comers to the hospital, so a number of fairly well patients. But you can see in the patients that were that died in hospital, around 35% of those patients actually needed renal replacement therapy. This is a slide, thankfully, shared with me by Eric Host from Belgium. He asked his colleagues around the world the number of patients that they were treating with renal replacement therapy, and you can see ranging between 0 and 37% of patients in the ICU are actually needing renal replacement therapy. And certainly 37% of a lot of patients is an awful lot of patients. And Adrina showed you this article in the New York Times suggesting that it's not only ventilators that are in short supply, but dialysis machines are. And not only are dialysis machines in short supply, but also the way these patients present. We know that we get these red cell aggregates in peritubular capillaries. There's probably thromboses in the lungs. And what people are seeing is that their hemodialysis filters are also clotting. And so they're really struggling to do acute dialysis because of this. Also, a major resource, especially in low and low middle income countries, but all over the world, is our renal nurses. And in our situation in the ICU, renal nurses are responsible for the CRRT and the intermittent dialysis. So if we've got a lot of patients on these modalities, the nurses are out of our renal unit and we're losing them to that. But more importantly, they then go back to the renal unit and at that point put our patients who are on chronic hemodialysis at risk of infection. So certainly there needs to be some thought as to what dialysis modality we use. So what is the ideal modality in patients with COVID disease? Well, it needs to be minimally affected by clotting. It needs to be readily available, and certainly in many countries it needs to be cost effective. It needs to be able to clear toxins in our hypercatabolic patients on the ICU. You need to be able to maintain a fluid balance, and I'll talk a lot about this later on. It also needs minimal need for our external nurses to come into the unit so that we limit the use of PPE and we also don't lose staff to infection. Now, just looking at some of the clinical factors that might be relevant to nephrologists. So the patients presenting with COVID-19 pneumonia were always thought to have ARDS, but actually it's not the case. On the left-hand photo, you can see patients that present with lungs that are typical of an early COVID patient, whereas on the right is a typical ARDS type patient. And most of the patients are in the left-hand column. And these are patients who've actually got very highly compliant lungs, but they've got poor diffusion, and this is due to the inability to vasoconstrict their pulmonary vessels when they are hypoxemic. They typically need a PEEP range of around 7 to 10, so not high PEEP like we would see with ARDS patients, but they do have a high FiO2 requirement. So these patients are actually easy to ventilate, they have low driving pressures, and certainly having fluid in your abdomen in these patients may not necessarily be a major problem. Having said that, later on they do tend to develop low compliance ARDS type lungs, and in these patients it might be more difficult to ventilate them, especially if you have a full abdomen. So we need to think about these patients carefully. There's talk about prone ventilation, and although it works well in ARDS where you recruit lung, in these patients a lot of people are prone ventilating them, more to improve their ventilation perfusion matching rather than necessarily recruiting lungs. But we need to think about this when we're looking at what type of dialysis we're using. Fluid balance is extremely important. ARDS is really an iatrogenic condition. These patients have leaky capillaries, lots of inflammation in their lungs, and if you overload them with fluid, they tend to get worsening lung function. So over the years, we've moved to a much more restrictive fluid strategy when managing patients on the ICU. And with that, we see a reduction in the number of patients with ARDS. So certainly we want a modality that can control that fluid balance. But at the same time, what's happened is a lot of people are using this restrictive fluid strategy in the COVID patients. These patients have very high temperatures, and it's been found that a lot of these patients are presenting to the ICU they're actually hypovolemic and may well need to be fluid resuscitated at some point. But once these patients are fluid resuscitated, we need to make sure that we control their cumulative balance on a daily basis and look for hidden fluids and things like TPN, nasogastric feeds, and make sure we're maintaining a neutral fluid balance on a day-by-day basis so we don't end up with ARDS. The cytokine storm syndrome does develop in a small proportion of patients presenting with COVID-19. It's typically due to a massive release of interleukin-6 due to the innate immune system. This leads to a number of problems and multi-organ failure and very high levels of cytokines in the circulation. And there have been a number of questions about whether we should be using CRRT, hemoabsorption, or even plasma exchange to treat these patients to try and lower the cytokine levels. And so in these patients, a lot of people are using CRRT on this basis. Now, it just must be cautioned that there have been a couple of studies looking at CVV-HDF in patients without renal failure with sepsis, who they've tried to lower cytokine levels. And actually, cytokine levels do not fall, even with high volume hemofiltration, when it's used to treat sepsis. And a study out of Paris actually showed that there was a shorter time to death in those patients who were hemofiltered. So certainly, I'm not sure that CRRT should be used specifically for cytokine storm. Having said that, these patients often have multi-organ failure. They often have very high lactates, often are fluid overloaded. So CRRT may be beneficial for these patients. So in terms of choosing a dialysis modality in these patients, I would use CRRT over PD. So what are some of the advantages of acute PD for treating AKI? Well, firstly, it's simple and you need minimal training. It's much easier to train a nurse how to do acute PD than it is to teach them how to do intermittent hemodialysis or CRRT. It requires minimal infrastructure. In some cases, no electricity or water. You can still do acute PD. And it is relatively cheap. There's studies out of Africa showing that the cost of saving a life is between $400 and $700 per life saved, which according to the WHO criteria classes it as a economically viable solution. The acute PD is cardiovascularly stable, so we routinely choose it over intermittent hemodialysis on the ICU for the patients on inotrope or vasopressor support. And we've got our own biocompatible membrane that we're using. Exposing the blood to an extracorporeal circuit does stimulate the immune system, whereas in acute PD, you're using your body's own biocompatible membrane. And that may be why we see such good results or some other reason. Certainly, I've talked about the need for anticoagulation, so you don't get clotting with acute PD, but also in pediatrics, the lack of need for vascular access is really helpful. And certainly the pediatricians use a lot of acute PD. You avoid disequilibrium syndrome in head injuries and patients with raised intracranial pressure. And there's some evidence that there's more rapid recovery of renal function with acute PD. But there are also disadvantages to acute PD. And one of the big ones is PD access. Not many people know how to put in PD catheters. And that is a major hindrance in terms of getting patients onto acute PD. But I know Elaine and Hugh are going to talk about this later, how they've overcome this. Increased abdominal pressure, that causes problems in two ways. One is it might limit your venous return to the heart, so patients who are cardiovascularly unstable, but it also affects on pulmonary mechanics. And certainly in a patient with raised intra-abdominal pressure, it's going to worsen it. You also can't dial in ultrafiltration volume. And that is a real problem for us intensivists because we like to have a knob that we can dial into and we can say in an hour we're going to take off X amount of fluid. But certainly that you can't do with acute PD. You have to look on a daily basis as to how you're doing. And finally, there's a risk of failure due to mechanical complication. Around about 5% of catheters don't work and you aren't able to actually dialyze the patient. So certainly you don't want to be doing acute PD in a patient who's in extremis about to die when you have another option which is giving you a guarantee that you're going to be able to dialyze them. Going back to intra-abdominal pressure, the studies from Brazil looked at filling abdomens and showed that the intra-abdominal pressure increases from about 8 to 12 centimeters of water. And that does have an impact on your ventilatory parameters. Certainly pulmonary static compliance did decrease in their patients, albeit to a small degree. And other studies have shown the same thing. This by Gokbal showed a 12% reduction in FRC. And this old study from Tudovsky looked at patients who are supine, and you can see that once they went over about 2.5 to 3 liters, your forced vital capacity did go down. But below that, it doesn't seem to impact on your ventilation too much at that point. So my recommendation is that when you have these patients who you're treating with COVID-19, certainly I'd be wary of starting acute PD in a patient who is breathing spontaneously, because you may tip them over the edge. But if they are on a ventilator, target an intra-abdominal pressure less than 18, and consider increasing your PEEP by about 2 to 4 centimeters of water, which will have the effect of counteracting that increased abdominal pressure. Just be aware, if your patient is hypovolemic, increasing that PEEP may decrease the venous return and cardiac output. So we really need to be trying to target our optimal PEEP. So if we look at the principles of acute PD, we're trying to clear small molecules, and we do this by diffusion. And we do this by rapid cycling of our PD fluid, creating concentration gradient. Middle and large molecules move by convection, and convection is a result of solute drag. So you need ultrafiltration to allow you to have convection. So we need the ultrafiltration, which we do through the use of high concentration glucose and creating an osmotic gradient. So this is an equilibration curve of different molecules in the peritoneum. And what you can see is that small molecules like urea, potassium, they equilibrate quickly. And usually over the first 1 to 2 hours, they're equilibrating. Whereas larger molecules like phosphate and beta-2 microglobulin, these take longer and they need longer dwell times to clear. So rapid cycling doesn't work well for these, but it does work well for your smaller molecules. In terms of fluid removal, remember that you put fluid in that's got glucose. That glucose pulls the fluid into the peritoneal space, but then you start to absorb the glucose, and in doing so, you start to reabsorb fluid. So what we want to do is we want to do our cycle when we're still on the steep part of the curve, both for fluid removal and for removal of the solute that we're trying to clear. So what's going to kill our patients? Well, hyperkalemia, acidosis, and fluid overload are what's going to kill the patient in the first 24 hours. So we want to do rapid cycles. We want to use high glucose concentrations if they're fluid overloaded, and that way we're going to be able to save these patients' lives and get them stable. But we need to think about middle molecules, especially in the septic hypercatabolic patient. So there we need longer dwells, we need convection. And once we've resuscitated the patients, we need a neutral fluid balance. And we're going to do that with an appropriate glucose concentration. So there's 2 ways of doing it. We can do a manual or automated PD where we fill the patient, we leave the fluid in to dwell, and then we drain them, and we get a small bit of ultrafiltration on each cycle. Or you can do tidal APD where you actually leave a tidal volume in the fluid, in the abdomen, and you cycle on top of that, and then you can choose how often you want to do a full drain, and with that you can then drain out the fluid that's in the abdomen. Now, the potential advantages of tidal PD is that if you are doing high volume filtration, there are some modeling studies that suggest tidal PD may improve your middle molecule clearance, albeit modeling studies, it's not real world stuff. But also if your patient's having problems with alarms and mechanical complications, sometimes leaving a small 20 to 30% tidal volume, residual volume in helps prevent those complications. Now we deliver the fluid either manually, and best if we use a closed system where we drain the fluid and drain it out, but that is very nurse intensive. Or if you're lucky enough, you can use an automated machine, an APD machine that's able to do that and deliver the fluid and drain it out for you. And especially in the COVID patients, something which is really helpful is using something like this. This is the Claria system, which has got remote patient monitoring software. So what you can do is actually from your office or from your mobile phone, you can actually see what happened to the patient over the last 24 hours. You can look at the ultrafiltration. You can see if there were any problems with mechanical drainage, and you can adjust their prescription from outside. So it means that you're using less in the way of PPE, less need to actually go into the patient. So I'm going to talk now about the ISPD guidelines. We wrote these guidelines back in 2014 for the first time, and they are freely available in Peritoneal Dialysis International and on the ISPD website. If you are doing acute PD at the moment, I urge you to look at these guidelines because they hopefully would be able to get you through dealing with these patients. But as I say, the guidelines are just being submitted for publication. And I just want to thank the authors that co-authored this with us, both the adult section and the pediatric section. I'm not going to talk much about pediatrics because fortunately the children don't seem to be as badly affected by COVID, but there are two sections to this. So the first question we asked is PD a suitable modality for treating AKI in adults? And we asked this in the first set of guidelines because we didn't want to offer a modality that was suboptimal for our patients. And we showed with a 1B recommendation using the GRADE criteria that it is a suitable modality. The new guidelines, we again have a 1B recommendation that it is a suitable modality for all settings, but based on even more evidence than we had in the last ones. So what evidence do we have? Firstly, this is a study out of Brazil by Daniela Ponce, where she looked at 60 patients and randomized them to acute PD or daily hemodialysis. And they showed no significant difference between 28-day survival or metabolic parameters between those patients on daily hemodialysis or acute PD. This is a meta-analysis by Dina Cruz's group, where they looked at the cohort studies as well as the randomized studies at that time, and again showed no significant difference between acute PD or extracorporeal therapies. This is a paper from Abdullah Al-Awaish in Saudi Arabia, and he did things slightly differently. He used tidal APD, which wasn't used in the previous studies, and used bicarbonate-containing solutions. And he compared CRRT, where they achieved an effluent, a dialysis effluent of 23 mils per kilo per hour, which is what we'd expect, and compared that to tidal APD. And he actually showed that there was a better survival in the patients on APD compared to those patients that were on hemofiltration, the red bars being the PD and the blue bars being the hemofiltration group. And this is a Cochrane review looking at acute PD compared to extracorporeal therapy, and you can see in the author's conclusions that based on a moderate evidence base, mortality and recovery of kidney function, there was probably little or no difference between PD and extracorporeal therapy for treating AKI. So certainly from those studies, we do feel that there is definitely value to treating patients with acute PD. And we certainly believe this in the Saving Young Lives program, which for those of you that don't know is a partnership between the International Pediatric Nephrology Association, the ISN, EuroPD and ISPD. And we train doctors and nurses in low and low middle income countries how to do acute PD to treat patients with AKI. And so far we've had over 400 patients treated with more than 65% survival with recovery of renal function and these patients going home. So we certainly believe in it. But sometimes people say, but that's fine for acute kidney injury, but what about our sick patients on ICU? So these are 5 studies. The first 3 studies are from Brazil, the fourth one from Thailand, and Abdullah's from Saudi Arabia. And what you can see is that these patients are in ICU and they're sick patients. Around 50% of them have sepsis, 60 to 90% of the patients are actually ventilated, and their Apache 2 scores are sitting in the range of around 25 to 27. So these are actually acutely unwell patients. These are proper ICU patients who are being treated with acute PD. And they're presenting quite late. Creatinines at the start of somewhere between 4 and 6 when they start their dialysis. When we look at Yang's paper out of Wuhan on the patients that presented there with COVID disease to their ICU, you can see these patients, their Apache 2 scores on arrival. These are the non-survivors were 18 and survivors 14. So certainly acute PD is a good option for patients in ICU. Next, what about PD access? So our recommendations are that we use flexible PD catheters. And the reason for this is that flow rates in flexible catheters are much better than rigid catheters or makeshift catheters. And these patients, we've got to put a lot of fluid in and out in a 24-hour period. So if the catheter doesn't drain very well, you're going to get suboptimal dialysis. So certainly that's our optimal range. But you'll see that we've made the guidelines suitable for people that are in low-income settings who may not be able to use a flexible catheter. So the optimal is a flexible catheter, but we also have a minimum standard. And the minimum standard says that you can use rigid catheters and improvised catheters using maybe nasogastric tubes, cavity drainage catheters, and other tubes, which may be life-saving in resource-poor environments. So certainly you can use these. Another strong recommendation is that nephrologists and nurses should receive training to actually be permitted to put these catheters into the bedside. There's good evidence that catheters put into the bedside by nephrologists produce as good, if not sometimes better, outcomes than surgically placed catheters. And the advantages of these catheters can be put in at the bedside in the ICU, rather than having to try and transfer this patient to a theatre and be turned down because they're hyperkalemic and therefore can't have an anesthetic. So here you can see putting a catheter in at the bedside with a peel-away sheath. We typically use a 10-cop catheter for our patients. But as I say, you can use makeshift catheters. On the right here, these are the rigid catheters. These are often used in India. They're much cheaper. My problem with them is that the flow rates are slower. They tend to be more prone to getting blocked, and they have been shown in randomized trials to be more prone to infection than 10-cop catheters. But they still save lives. This is a child with a nasogastric tube inserted surgically in Nigeria, and this was an intercostal drain that I had to put in under local anesthetic in one of our rural hospitals with a patient with AKI. So really, if it's a tube that allows fluid to go in and out, it's probably going to save lives. This is a catheter that I'm quite interested in. It's the Arrow percutaneous cavity drainage catheter. You don't have to use a peel-away sheath. You insert it using a Seldinger technique, and then you load the catheter on this introducer and place that catheter into the abdomen. And on the right is a patient of mine who had acute pancreatitis. The surgeons had put a catheter in because he had raised intra-abdominal pressure and ascites, but when he developed acute kidney injury, I actually attached it to an APD machine and dialyzed him for a week using that catheter, and it worked very well. What about fluids? So in patients who are critically ill, if they have liver failure or they've got poor hepatic perfusion, they often can't convert the lactate, which is a buffer in most of our solutions, into bicarbonate and therefore correct the acidosis. So in these patients, the optimal is that we use bicarbonate-containing solutions. Unfortunately, in many places, you're unable to get a hold of bicarbonate-containing solutions. So still as a minimum standard, if you have nothing else available, then you can use a lactate-containing solution. But if you've got the option of CRRT or acute PD in a patient who's got a lactate of 5 and profoundly hypotensive, I would probably put that patient onto CRRT over acute PD. But it doesn't mean you can't use these solutions. Also, our recommendation is that you use commercially prepared solutions because they are much less likely to cause infection because of the way they are made, as well as their connections are a little bit easier to use. But again, in many countries, they are unable to get these commercial produced solutions, and you can save lives mixing your own solutions. So this is in the guidelines, in both sets of guidelines. You can see the top table looks at our common solutions, Hartmann's, Ringer's lactate, and Plasmolite B. And you can see that the electrolyte consistencies are fairly similar between that and our commercially available fluids in table 4, apart from the fact that there's potassium in these solutions, albeit in low concentration, but also the osmolality is higher, obviously, in our commercially available PD fluids. So in the guidelines, there is a recipe of how you can actually mix your own solutions using Ringer's lactate, adding 50% dextrose, and you can make yourself a 1.5, 4.5, or a 2.5% solution. And one of the concerns with this is, could you be causing these patients to develop infection? Well, if you do it carefully, no, that's not the case. And this is one of our Saving Young Lives sites in Cameroon, the Mbinga Hospital. And they were donated commercial solutions initially, and 25 patients used commercial solutions. Following that, they had to mix their own solutions using Ringer's lactate and bicarbonate and dextrose. And you can see peritonitis rates were actually the same between the two groups. So if you do it carefully, and this is the important part, as long as you're sterile in doing it and the nurses know what they're adding, there is certainly no evidence that it is worse to mix your own solutions. What about prescribing PD and AKI? So our original guidelines, the data that we had was based really on that one study from Daniel Afonso looking at comparative daily hemodialysis versus acute PD. And that was the only outcome data that we had for survival in patients on PD. And so we had to settle on a weekly KTV of 3.5, which was what was achieved in that study. If you targeted higher dose, you probably don't improve outcomes. But we realized that the volume of fluid used there was going to be too high for many of our low-income countries. And certainly if you extrapolate from the CRRT studies, maybe we should actually be targeting a KTV of 2.1. And so that was our minimum standard in the last guidelines. And just to remind you, a KTV of urea is looking at urea clearance. And there's debate as to whether we should be using this as a target, but currently it's what we've got. Our new guidelines are slightly different because we have some new data. So you can target a KTV of 3.5, and that does have comparative outcome to a daily hemodialysis prescription, and that targeting higher doses doesn't improve outcome. But that dose may not be necessary, and that targeting a KTV of 2.2 has actually been equivalent to the higher doses, and that's a 1B recommendation. Also, that study from Abdullah Al-Awaish using tidal APD showed equivalent outcomes in survival compared to CVV-HDF if you use tidal APD with a 70% tidal volume. So there's a few options, and I'll go through later how we do this. But going back to the Brazilian study, so here you can see they were using between 36 and 44 liters of fluid a day, and they had a dwell time of between 35 and 50 minutes, and they achieved this very good clearance. But they then wanted to aim even higher, so they looked at targeting a KTV of 4.13, or higher than that, but they achieved 4.13 and compared it to an achieved 3. And what they found was that there was no difference in survival. So very much like we see in our CRRT studies, that there seems to be a lower threshold, and if you aim higher than that with more dialysis, you don't seem to get any more benefit in survival. Also, if you're doing these rapid cycles which are being done, one of the problems is you use quite a lot of fluid. Remember, when you're doing acute PD, you've got to account for the fact that you're draining in and you're draining out fluid. And that's not good dialysis time. The dwell time is when your fluid is in contact with the peritoneal space. So just the simplified view, if you're doing hourly cycles in blue, you're going to use 48 liters over 24 hours, and your dwell time will be about 12 hours. If you go to 2 hourly cycles, you'll use half the amount of fluid, and your dwell time will be similar, if not more, in these patients. Now, that's a simplistic view, but it led us to look at the slightly lower target in terms of dialysis. And Watanu from Thailand actually then took our guidelines and did a randomized study in patients in ICU and compared the optimal intensive strategy and then looked at the minimal standard. And what they achieved was a KTV of 3.3 or 2.26, which was fairly close to what our recommendations showed. And what you can see is that there was no significant difference in terms of their metabolic parameters, and actually survival was slightly better in the group, albeit non-significant, in the low intensity group compared to the high intensity group. So certainly we are happy in these patients that actually we can aim slightly lower in terms of the amount of dialysis. But the one thing I do want to show you is that in the Brazilian studies, you can see that the ultrafiltration rates were actually pretty good, 2.4, 2.1 liter. Whereas in the minimally intensive arm, the ultrafiltration wasn't quite so good. So you may well have to use higher concentrations of glucose if you're going to be using less intensive fluid strategies, or if you're wanting to remove more fluid, you might have to do more rapid cycling. So this is the guidelines, this is the algorithm that we've got in the new guidelines. So patients have got dialysis indications. Blue is our optimal, orange is the minimum standard. So optimally, we're going to use a flexible PD catheter, but if you don't have that, you're going to use a rigid or makeshift catheter. If you've got shock or liver failure, you're going to try and use a bicarbonate buffered solution, but if there's no shock or liver failure, a standard PD solution is optimal. If you don't have commercial solutions, then you can mix up your own solutions using Ringer's lactate or Hartmann's along with dextrose water. In terms of the cycles, so if your patient's less than 60 kilograms, you're going to do 1.5 liters, 120-minute or 2-hourly cycles. That means that your dwell time is going to be around about 90 minutes. If you're 60 to 80 kgs, you're going to use 2 liters with 120-minute cycles. And your larger patients, you're going to have to shorten your cycle time using 2 liters. I wouldn't necessarily recommend going to bigger volumes And the reason for this is that you may be prone to leak, and you may also increase your intra-abdominal pressure, because obese patients tend to have higher intra-abdominal pressures to start with anyway. So your cycle time will have to shorten. What you then want to do is look at this patient after 24 hours. If they're still hyperkalemic, acidotic, and have fluid overload, so it's not corrected, you're going to stay in this cycle of rapid cycling. But once you've corrected these, you can then move to longer dwells and use this strategy in terms of your cycle times, depending on the patient's weight. So in summary, I'm just going to give you my personal opinion on COVID-19 and PD for AKI. I certainly think it is suitable for our critically ill patients, and it is certainly going to preserve our nursing staff, our PPE and consumables, or at least allow us to use it more rationally. I think it should be used in those patients who are less hypercatabolic, and reserve our CVV-HDF or CRT for the more profoundly multi-organ failure patients, or those that are significantly overloaded, where it may be more beneficial in those patients. PD can be used as a bridge to getting these patients to the ward, thereby freeing up dialysis resources. And I would also consider starting slightly earlier. Now, I strongly believe that, and the evidence supports this, that we should be waiting until patients have the classic criteria for dialysis, acidosis, hyperkalemia, fluid overload, and encephalopathy. But if you've got a patient who's anuric on the ICU, their creatinine's rapidly rising, and they are becoming fluid overload, think of starting maybe 24 hours earlier by putting the PD catheter in. It just allows you a slightly more space to get these patients dialyzed well. Don't be scared of high concentrations of glucose. Remember, fluid overload is more dangerous than high concentrations of glucose, but you may have to control the glycemia well with either intravenous insulin infusions or subcut sliding scales of some description. And although it's not evidence-based, I think it's worth monitoring your intra-abdominal pressure and adjusting your volumes accordingly, trying to keep your intra-abdominal pressure on the lower side, especially in the patients with poor pulmonary function. Thank you.
Thank you, Brett. I hope you can hear me now. I think I have unmuted my microphone. So Elaine Bowes, who's our senior PD nurse, and I are just going to talk about our experience at King's of using acute PD in COVID patients on the ITU. So we started doing this about nearly 4 weeks ago now at King's. So just a few things about the background. So London of all of the UK had the earliest and largest numbers of patients with COVID, and at King's, partly because Southwark, which is our main London borough, had the highest incidence of COVID in the early stages. So King's had very large numbers of patients with COVID and very large numbers of patients on ITU. Initially, there was some evidence that the AKI rate actually at King's was higher than in other centres, and initially it was about 50%. So we therefore had very large numbers of patients with AKI on our ITU. Quite early on, the ITU staff and we identified that there was going to be a potential shortage of the machines to do a CVHDF, and therefore we needed to be thinking of other ways to dialyze these patients. At King's, as a renal unit, we have a history going back many years of doing a large proportion of our PD catheters under local anesthetic by either nephrologists or by the nurses, with Elaine as the leader of that. And we also have some experience of using PD acutely. We use it quite commonly in crash landers, so crash landing, end-stage renal failure, and also we use albeit not on ITU, for acute kidney injury. And then, of course, following on from the shortage of HDF machines in the past week to 10 days, there's now been a national and an international shortage of consumables for HDF. And so that has driven us even further to consider PD as one of the options to be dialyzing these patients on ITU. So as I say, we started putting PD catheters on ITU nearly 4 weeks ago. Initially, those were done by Elaine and me as consultant nephrologist. More recently, we've been training another nephrologist and also have just started training one of our interventional radiologists. We've in part done that because we recognize that many renal units in the UK do not have nephrologists insert PD catheters, and we thought training up interventional radiologists might be something that could be done very quickly across the whole UK. Obviously, the catheters are inserted in the intensive care unit at the bedside. In many ways, it's easier than our normal patient for catheter insertion because the patient's sedated and ventilated, and therefore analgesia is obviously not an issue. It tends to be a bit quicker, and consent seems to have slightly gone by the board because of the current emergency. We're using our normal selection criteria for local anesthetic PD catheters, which is a blind Seldinger technique. So we don't like people to have significant abdominal scars, particularly none around the umbilicus. Normally, actually, we would say a hemoglobin of probably greater than 90, but in this situation, we're saying greater than 70. We'd like them to have relatively normal clotting, normal platelet count, and not be too obese. Because we're seeing very large numbers of obese patients on ITU with significant COVID and ventilation, we've somewhat relaxed our BMI limit. It used to be 35, but in fact, we've now been putting PD catheters in significantly heavier patients and have put catheters in some patients over a BMI of 40, which can be a bit of a challenge. Constipation, obviously on ITU, is a major problem. We like to give the patients citrafleet on 2 occasions in the 24 hours prior to the procedure, and ideally not 8 to 12 hours before actually putting in the catheter because of increased amounts of intra-abdominal wind. In some patients, we need to repeat and also give a phosphate enema, but this protocol has worked fairly well. Normally, we'd give a gram of intravenous vancomycin pre-procedure, but a lot of these patients are already on broad-spectrum antibiotics, so we often will just accept that and not give any additional agents. I made this slide a couple of days ago, so in fact, we've now attempted insertion in 34 patients. Of those 32, we've been successful in 27. Of the 34, we've been successful in 29, so the last 2 have been fine as well. We failed in 5 patients. In 2 of those patients, we got into the peritoneal cavity. In 1, we couldn't advance the wire, and the other one, when we put the needle in, we actually aspirated air, indicating we punctured the bowel. Procedure was abandoned, but in fact, the patient, as quite commonly happens in this situation, actually had no sequelae and remains fine, albeit not on peritoneal dialysis. And in 3 patients, because of obesity, we were unable to reach the peritoneal cavity with our standard 5-centimeter needle. We're just starting to try and access some longer needles, and with ultrasound can hopefully get into these patients' peritoneal cavities. So what about our outcomes? So PD has worked in all patients, and for the large majority, they've managed to switch from CVVHD if they're already on that to PD and just remain on PD. 1 patient was very unwell, continued both PD and CVVHDF for progressive acidosis. In fact, they died after 5 days of COVID and multi-organ failure. 3 patients, the ITU team, and I'll talk about this again in a second, very used to continuous filtration where they generate very good biochemistry, and in particular the NT team, when they do tracheostomies, have this idea that the urea needs to be quite low, and therefore we've had 3 patients who had 48 hours of CVHDF to bring the urea down so they could have a trachea inserted. 1 patient had a persistent ileus with bowel distension on plain abdominal X-ray. We actually continued PD. The ileus was just thought to be related to being on ITU and a ventilator. It resolved, and in fact, the patient has recovered function. I took his catheter out 2 days ago, and his creatinine is now 77. We haven't had any ventilation issues related to the PD therapy. and none of our patients have required proning after PD catheter insertion, so we haven't answered those questions about leaks, increased intra-abdominal pressures. Just in terms of the outcomes, although it's relatively early days, 7 of the patients have recovered renal function. 5 of the patients, we removed the catheters. 1 was pulled out by the patient in a confused state, and we've removed the other 4. 3 patients are currently holding PD because they're passing urine and their biochemistry is holding, but they've not yet recovered enough function to say their AKI has resolved. 3 of the patients have died of COVID, so a relatively small percentage. 14 patients as of yesterday remain on PD. I think it's now 16 with the 2 catheters we put in the past few days. And of the 5 patients where we failed to get the catheter in the peritoneum, they're all still alive. They remain on ITU, but they're either on HDF or intermittent hemodialysis, which we've just started doing on the ITU to cope with the large numbers of patients requiring dialysis. In terms of complications, so aside from needling the bowel, on 1 occasion, there's been no evidence of any bowel injury or any hemorrhage. We haven't had any leaks, no exit site infections, and no episodes of PD peritonitis. Prior to yesterday, when I made these slides, there'd been no evidence of catheter migration leading to poor drainage. In fact, 1 patient yesterday had poor drains. Abdominal films showed quite a lot of constipation, and the catheter up on the left-hand side. So that catheter obviously has migrated out of the pelvis. We've had relatively few alarms, although the patients need to continue laxatives, and in some patients, the ITU have used fecal management systems for sort of practical reasons, but it seems to work quite well. As I've said, none of our patients have required proning since having their PD catheters put in, so we haven't answered any of those questions there. Elaine's just now going to comment on the PD regime itself. Elaine?
So currently we have put all of those patients on automated peritoneal dialysis, but we have considered CAPD, and certainly we use CAPD in 1 particular patient who continued to be quite constipated after the catheter went in for the first 12 hours, and that worked actually very well. So UF was quite good in that patient in that time. We are using the Baxter Claria Home Choice and Fresenius Harmony machines, though we will say that the actual Claria machine, we're able to use more fluid. So we have 30,000 mils of fluid in some of our patients. Hugh, would you mind going to the next slide?
Yeah.
So in regards to prescriptions, and I think this is what people will be most interested in, we have in our first session started the patients on either between 12 and 18 hours of dialysis, and that is patient dependent. We haven't started any patient because we haven't had any patient who required less than a 1200 ml fill. And I will say probably putting on into small a fill can cause problems with alarms, and so some of these patients are very, very large. I think our largest patient was 125 kilos, and so we started him on 1600 mils immediately, and he dialyzed very well with no drainage issues. That particular catheter was put in with the interventional radiologist, actually providing pressure on the abdomen as well as ultrasound guidance, which was very useful, and I think probably wouldn't have been able to get that catheter in without that. So that was actually a learning process for me. So cycles, on the first session used between 9 and 14 cycles. The dwell time is very dependent on the patient's biochemistry. So we have used more rapid exchanges, as in 20 mil dwell times on patients where biochemistry, the ITU team wanted it to be moved very quickly. And I will reiterate what Brett has said about using, so I've said that we are using 1.36 or 2.27. We have been using more often now 2.27 and the 3.86 bicarbonate bags, so Physioneal or Balance, depending on which system we've used. And I think offloading the patient quite quickly over the first 24 hours for these COVID patients not only improves the patient's respiratory condition, but also it allows the ITU team to see what we can do. And I think one of the things is to make sure that the intensivists understand that we can remove fluid and we can do it quite rapidly. And I think we have managed to remove at least 2.5 litres of fluid in that first 16 hours on many of our patients. We then, a couple of days later, will move to session 2, where we will either increase the fill volume, and as I've said, leaks are not really a major problem in ITU because the patients are generally supine. And also once the catheters are in, and obviously exit site placement is very, very important. We have been using more lateral exit sites just in case we do end up proning the patients. But importantly, where the exit site is, it allows the drainage of that catheter. As you have said, Brett, we have been using the silicone catheters, double cuffed, generally either 57 centimeters, 63 or 62 centimeters, depending on the patient's size. And I think it's important to consider that so that the catheter is long enough or indeed short enough, depending on the patient. So again, those dwell times we've then been increasing to between 30 and 75 minutes, and dextrose concentration basically according to the UF that we required. And in session 3, that is where a couple of days later we will actually then use extraneal or a final fill, and we have been able to rapidly do that without any problems with leaks. And again, we can reduce the total fill volume at that point, and this is when patients are indeed recovering function. So I think the next slide, please.
Yeah.
Hugh.
So should I just talk about that?
Yes.
So just a few sort of general comments. So we've certainly found that the initial review and then inserting catheters on ITU is quite time consuming. We're also aware that not all renal units, particularly in the UK or elsewhere, have experience of inserting catheters, so that obviously is an issue. It's a big workload for the PD nursing staff. We have 15 to 20 patients. It's a physically very demanding environment in ITU. It's very time consuming. Communication can be difficult. And we've certainly found that moving volumes of PD fluid around the hospital is quite difficult as well. We're recruiting runners both from ITU and elsewhere to help. Work on medical staff is difficult. I find if I'm spending time putting in catheters, I need additional consultant and junior doctor input to help with the daily reviews. And as Brett sort of indicated, one of the issues is, of course, about the education of and liaison with the ITU staff. They're used to, in the UK, using CVHD. They can control the biochemistry, they can dial in fluid removal and things. So it is quite a learning experience for them. Kings, we now have 7 or 8 separate ITUs because of expansion, and there are lots of staff, and engaging with them has been challenging. They're very keen and they think this is very successful, but it's not a trivial workload, and we haven't really been able to train the nursing staff in ITU, so there are issues with machine alarms, drainage, etc. But so our conclusions are, however, that certainly PD works and is safe for AKI in COVID patients on the ITU. We think anxieties about leaks, wound breakdown, and peritonitis are incorrect, and it doesn't seem to be a problem. We managed to reduce the use of both machines and the consumable CVHDF, but it is a major workload for the whole PD team. Okay, thank you.
Thank you, Hugh and Elaine, for presenting that information. And I wanted to first thank the ISPD and the ISN for hosting this event today. I think the information shared is very valuable for the nephrology community broadly. I also wanted to thank my colleagues presenting today for the information, because this is something that is a very hot topic. As mentioned, I am one of the clinical nephrologists at LSU School of Medicine in New Orleans. And as has been seen, we've had a rapid increase in the number of COVID patients in the New Orleans area, although it seems New York seems to be on the news more than we are. But we've had a very high per capita infection rate, as well as a very high death rate per capita. As heard earlier by Brett, there are many countries doing PD for acute kidney injury, but In the United States, this is actually not very common. And so we've done urgent start PD, but this is a new sphere for us, and we're trying to wrap our hands around it. What we've seen is that, as noted earlier, and I don't need to review that, but within our institution, we're seeing between 25 and 30% need for renal replacement therapy in our COVID positive patients, based on some preliminary data digging that we've done. And always everyone wanted to talk about on the news was the need for ventilators and ICU beds, but as mentioned multiple times today, that New York Times article highlighted the issue that we were experiencing was not the lack of ventilators, but actually the difficulty in providing renal replacement therapy for the patients. So initially when we started presenting, we noticed that we were trying to do CRRT, but there was significant issues with clotting. And then eventually we tried to do intermittent hemo, but the staffing ratios were insurmountable. And ultimately we were having difficulty providing the renal replacement therapy needs for the number of ICU and critically ill patients throughout the hospitals. So at that point, we decided that we needed to think about acute PD as an option, especially since we had some experience with urgent start PD. And using the ISPD guidelines, we developed our own acute PD protocol, similar to what was presented by Elaine just a few minutes ago. This really helped us think about how to utilize resources and patients that were a little bit more stable to do acute PD, whether in the ICU or on the floor, to limit the number of one-to-one treatments that were required for these isolated patients. And then the hypercoagulability issue, which allowed CRRT difficult to do, we didn't see with the PD, and so that actually helped for those patients where CRRT was just not functioning. As mentioned, the biggest things to think about, especially for us in the United States and in North America, is who's going to place these catheters. Generally, these catheters are placed laparoscopically by our surgeons, but there are more and more interventional radiologists and interventional nephrologists placing them percutaneously. We were fortunate in our institution, our surgeons were willing to place these catheters in the ICU ventilated patients. They placed them at the bedside. For those patients on the floor, they took them down to the operating room, but we're very mindful about laparoscopy, especially given the gas release and the CO2. And so therefore they did a mini laparotomy in the operating room and placed the catheters that way. We were also very mindful of the patients we were selecting. So we avoided patients who were either prone or would need proning, especially if the proning was more than 12 hours a day. Patients with severe hyperkalemia or massive volume overload were probably not the best candidates, and so we avoided those patients, and anybody who had significant abdominal surgery. One of the other keys was really making sure that everybody was on the same page as far as the protocols go and how to place those catheters. So we shared resources such as Dr. Crabtree's videos online, or some of the vendors for the catheters have webinars on how to place percutaneous catheters at the bedside. And so we shared those with all of our interventionalists and our surgeons in the area. We also did a similar prescription. We ran the patients with low dwell volume rapid exchanges for 24 hours in the ICU. In this picture here is how we did it in the ICU, running extension tubing and keeping the machine on the outside in order to allow our nurses to once a day change out all of the cycler fluid and resume dialysis on these patients. On the floor patients, we did it 12 hours overnight. We started around 1 to 1.5 liters, and every 2 to 3 days, if there were no leaks, we increased by about 50%. We made sure that we had patients on an appropriate bowel regimen. We had our nurses understand, our acute dialysis nurses doing PD with these low volumes, sometimes requiring tidal. And then every day we monitored for clearance and ultrafiltration goals to make sure we were achieving the needs of our patients. And this ended up being very successful across multiple hospitals in the region. So what have we seen so far? As soon as we launched this, we've been doing this now about 3 weeks. I held a conference call with all of our local nephrologists in the city, as well as our surgeons, which was a great way to share ideas with one another. We've had about 18 patients so far on AKI PD across the region in multiple institutions. We've had 3 patients who've deceased, although these were all non-dialysis related. Patients did receive good ultrafiltration and clearance based on their labs, but they had multi-organ failure. We also used 2.5% dextrose on most of the patients, and we were able to get about 2 to 2.5 liters off each day. There were 2 patients that were ultimately discharged to our outpatient PD unit or cohorted COVID positive unit, and we had 1 patient so far who's recovered renal function. The remainder of the patients are still in the hospital, but doing well on PD. We did have 2 patients that had catheter dysfunction and required going back to the operating room for maneuvering of the catheter and placing it down in the pelvis again. But afterwards, it worked just fine. And so we've had no other failures. And everybody who was placed on PD was able to stay on PD at this time. One of the biggest challenges in the United States, and this is probably unique to what we experience, is figuring out how to get funding for these patients upon discharge. As I mentioned, PD for AKI is not something that's routinely done and therefore not routinely reimbursed. And we were fortunate in that the 2 patients that did transition to the outpatient clinic did have payers that were commercial insurance payers that were willing to pay for AKI PD, but there are multiple payers that will not, and therefore it's important for the case manager and the social worker to work with them and the dialysis companies to see if this is an option. Otherwise, we're probably going to have to change those patients back to hemodialysis. And with that, I'll turn it back over. Thank you very much.
Okay, well, thank you very much indeed for our speakers. It's been really, really excellent to hear your experiences, and I want to be the first person to congratulate you all on the work you're doing. So my name's Simon Davis, and I'm going to just deal with the Q&A session at the end of this seminar. We're already gone past the hour, but I'm assured by the organisers that we can continue, and judging by the large number of people who are still on the call, I think we should certainly do that. We've still got well over 900 people listening to this. So I've got a number of questions to cover. I've picked up quite a few during the course of the webinar, and my best way of dealing with that is to group these together. And I think the logical way is just to go through the process really from the start. So if I could ask, actually, I think we'll start with the guys who are doing the COVID treatment themselves. Because we heard from Brett how it is you choose between doing PD versus CVHD, but I would like to hear a little bit more about the nitty-gritty of that decision in terms of really how did you choose, particularly perhaps your first couple of patients, to do PD. Do you want to start, Hugh, with that question?
Yeah, I mean, I suppose most of that actually is the decision has initially anyway has been taken by ITU in that they said, so King's has had, I think, between 40 and 50 patients with AKI requiring renal replacement therapy ongoing for the past 3 weeks. And what's happened is that ITU, I think, initially identified patients who were reasonably stable in a ventilation sense, who they thought their abdomen would be suitable for a local anesthetic PD catheter, and therefore they invited us in. As time has gone on, we've been involved with more of the patients, so we've been discussing the entire cohort of patients who are having RRT, and we've said, yes, we think this person's suitable, this person not. I mean, sometimes it's, you know, they've had significant abdominal scars, sometimes they're very unstable, sometimes they're very obese, and that's made us say no, but otherwise we've just accepted anybody. As I said earlier on, a lot of this has been driven by resources that ITU has just felt they're running out of machines and more recently consumables.
One of the questions we've had is, have you done this in people with shock or with requiring a lot of inotrope support?
Certainly some of the patients have been requiring inotrope support, but we haven't done it in a sort of scientific sense to say, oh, here are people with shock, should we see if PD is better than CVVHD? So we haven't looked at it in that fashion. Yeah, I don't know if Brett feels that we should be trying to do that.
Yeah, I mean, those studies from Brazil and from Saudi. There were about 70% of patients who were on vasopressors in those studies. So certainly you can do it in patients on vasopressors. What I was saying is that if they have poor liver perfusion, those are the patients you might want to consider CVVH rather.
And do we have a consensus
I think,
that not using it in prone patients or not?
Well, so as I say, we haven't used it in any prone patients yet. We're keen to do so, but none of the patients have required it. But we would like to measure the pressures, look for leaks and things. But we haven't managed to do that yet, but it's on our agenda.
We've also avoided it in the prone, but if they're prone only 12 hours and then supine, we would do it in those patients when supine.
Yeah.
There's a case report of doing it prone in a patient a number of years ago, showing no problem with fluid removal and clearances. Also, when you turn a patient prone, studies show that you only increase the abdominal pressure by about 2 centimeters of water. So if you're turning the patients prone, ideally, if you put a pillow under their chest and a pillow under their hips, you actually then suspend the abdomen and you take the load off the abdominal pressure. So certainly that's something you can try. I think the main thing with turning patients prone is that you've usually got about 20 people trying to turn a patient over, and it's the best time to pull a PD catheter out. These catheters do come out easily, so you need to stick these catheters in pretty well if you're going to turn them prone.
Yeah, one of the things we've done is identifying patients may need to go prone is to make the PD exit site much more lateral, so it can be seen and got to by the nursing team when the patient's prone. Yeah.
Elaine,
I don't think we have precise in regard to being concerned about patients that might need proning. I think just the patients just have improved, either very much improved or not after we put the catheter in, so they haven't required proning for those reasons.
So one of the other set of questions we've had relates to staff requirements, which obviously must have something to do with how you choose to allocate your cases. And I guess there's a number of related questions to that. One is, do you think that this must be dealt with by experienced PD people, doctors and nurses I'm talking about? And if so, what was the sort of, how much staff time have you needed to put into this? Can you give us a ratio of a PD nurse per patient? One person's asking, do you have to have PD input for 24 hours a day? So there's a series of questions around that. I know, perhaps Elaine, you're going to deal with those, as I know you've dealt with that.
So we have, in relation to the PD catheter insertions, we have been running that through 3 personnel, myself, Dr. Cairns, and our interventional radiologist. We've also been teaching another consultant nephrologist how to put in these PD catheters. In relation to PD staffing, we have been running 12-hour shifts. So in the morning, we go around in 2 teams where we take the patient's machines down, we review their results, we decide what their prescription is going to be, and we look at all of their information and make sure that the intensivists are aware of what we're trying to do and that we've had conversations with them. Once we've done that, there is then a team of people going around and putting in PD catheters. There will be also 2 teams basically putting the patients back on dialysis through the day. We have had an on-call, because we have had some nurses who have actually been off unwell. Some of those nurses have actually provided a remote on-call to the ITUs. We've also had our renal ward offering some assistance with problem solving for our patients on our ITU. Having said that, it's very rare has to physically go to ITU overnight to deal with anything. I think it's much more in relation to good catheter placement, making sure that we're using the right volumes of fluid to reduce the alarms. And we are very lucky in that we have been able to redeploy some of our Our nurses have been quite impressed by the fact that a lot of our nurses have come back to us, nurses that I've worked with over the years, and they have actually, and we actually had an offer of a nurse from outside the trust wanted to come in and work with our team yesterday. So luckily, we have a lot of nurses wanting to come back and be involved in this. I will say that annual leave and days off have gone by the wayside quite a bit during this last 3 weeks. However, people are very keen to be involved. We did initially also train 2 of our SPRs because we didn't have enough nursing team to actually strip the machines and actually put the machines back up. And they very quickly were able to learn how to do that and to follow the right protocols. We haven't looked at training the nurses in ITU because the turnover of staff in ITU, and many of the staff in ITU are not actually ITU nurses. They are nurses that have been redeployed into ITUs at the moment. And we have tried to keep it in-house per se. And we have done a lot of training, and we have actually sent them a lot of information in regards to maybe taking the patient off to go to ultrasound or CT scanning or whatever, so that they're not waiting for us.
Thank you. Minha, did I understand that you were running it across the city in different ITU settings?
So no, we are running it. Oh, sorry.
That was really for Minha.
Apologies.
From Orleans.
Oh, sorry, I was on mute. So we had actually at 3 different hospitals, we were running acute PD through a collaboration of nephrologists, 2 community-based nephrologists in the LSU group.
But you're essentially using PD expert staff to do that.
So the dialysis nurses are all the acute dialysis provider nurses that come from the LDOs. They provide acute inpatient dialysis. And then the nephrologists are nephrologists who routinely do prescribe outpatient PD and felt more comfortable utilizing it. Yeah.
Great. So just, I think you've covered most of the points that I wanted to raise around catheter insertion, but there are 1 or 2 people asking questions about, for example, how quickly can you use the PD in that very early stages, and do you have a strategy in the early stages of using the PD?
Elaine?
Or
so we can use the catheters immediately, like within an hour of the catheter going in, we can start the dialysis. We are learning that it's a good strategy to offload the patient, as Brett has indicated, and to use strong fluids, especially in the first 24 hours. Not only does this allow us to improve the patient's respiratory status, but it also allows us to gain a little bit of confidence in the regime. Intensivists definitely want to see UF, and if they see that, then they're quite happy with what we're doing. After that, we try to slow things down, and of course we work as a team with our consultant nephrologists and our intensivists to decide exactly what fluid balance we want for that patient. I think one of the difficult things is, of course, we cannot say we're going to remove 100 mils an hour on that patient. And that's been quite difficult. The intensivists find that quite difficult. The nursing team find that quite difficult. But we have added an extra layer of UF and etc. onto our intensive care flow charts, and now they seem quite happy with what we're doing because they can see exactly what's happening and when it's happening.
Brett, should we be running these people dry or wet or whatever?
Euvolemic. You know, it's certainly that's what I'm saying, is that you want to make sure that the patients aren't dry, because they're not going to recover their renal function if they're dry. But certainly what I see more commonly is that there's this surreptitious fluid that creeps in with a big dose of an antibiotic, TPN, things like that, and you've got to watch out for that and try and maintain that neutral balance. So every day, what I would do is just check your fluid balance on your ICU chart, see how much fluid has gone in, estimate your insensible losses, and then you try and see whether you're achieving that with your PD. If you are, great. If you're not, increase or decrease your glucose concentration in your bags. and adjusted accordingly.
There was a mention of use of icodextrin at one point. I think was it the King's Group mentioned that. I would be a bit worried about leaks with that.
So we have used it after several days in some patients because we're reducing the amount or maybe the hours of dialysis they're having through the day. We haven't had any issues with leaks, and of course it does provide extra UF for that patient if we're not going to be providing. We might be providing 12 hours of dialysis rather than 18, and also obviously. We don't know how if we are going to have problems with fluid supplies, so we're trying to be clever about what we do with our AKI recovering AKI patients. But no, there hasn't been any issues with leaks thus far.
And my understanding is that really you've predominantly used APD in this situation rather than CAPD.
We have done so. We are open to using CAPD. We have increased the amount of CAPD fluid that is in the unit because the reality is we are probably, if we continue in the same vein, we are probably going to run out of available machines. Machines don't seem to be a particular problem at the moment. The bigger problem is the ancillaries, especially 8-prong cassettes for those bigger volumes of fluid like 30,000 units. And so there is certainly an option where we would have healthcare assistants or health technicians on the ITUs just going from patient to patient doing CAPD. And I think that's, if that's what you can provide, I think that is an equally good way of providing this. I'm sure, Brett, you have a lot of experience in this, and I'm sure that's...
Do you want to comment on that, Brett?
I certainly think that we mustn't discount CAPD. That's what we do in a number of our patients because we don't have machines, and the nurses are trained how to do acute PD. So it does use man hours, and APD is nicer. Having said that, it works very effectively. The other time I find CAPD helpful is a patient who has got mechanical complications. Often, actually, if you change to CAPD, you can often get better fluid removal in those patients. So if the machines are alarming a lot, then you could consider doing that.
The issue I think we have with CAPD is really a staffing one, which is that I just don't think we can train the ITU nurses who are sort of flat out and changing all of the time, and they normally look after one patient. They're currently looking after 4, and so we can't train them. And the issue with the CAPD team, the PD nurses, is going in is just too time consuming, and getting in and out of ITU. You know, we have 7 or 8 ITUs. They're moving around. Each one's using PPE. It takes 5 minutes to get in, 5 minutes to get out. So I think that's why we've not used it. But I take all of your points about it's good in some patients.
Yeah, I would just like to make the comment. Just out of a COVID environment, when patients, because a number of people will be using PD for AKI once this is all over, that CAPD certainly is a good option, especially in our low resource centers. So I don't want people to feel that you can't do it if you haven't got an APD machine.
Absolutely.
So we've had quite a lot of questions around the concern about the virus being in the PD fluid. And obviously the implications that has for disposal of the PD fluid and the plastic. I've seen data which is currently being submitted for publication, which suggests that with patients with COVID, actually, it's quite difficult to find virus if, well, in fact, they've not found virus in the PD fluid. But my view is that is not cast iron. So I think you must take the adequate precautions of removing the fluid usually by the toilet or the sluice available, and destroying the plastics. But if there's any thoughts on that from the team or the group, I'd be very, very interested to hear that.
So we have discussed that with our virologist. He feels it probably it won't be a problem, but we are endeavoring to measure it, or at least look for the virus.
So I think the advice at the moment is probably not, but you still have to take the careful precautions as you would do as normal. But it shouldn't be a reason for not doing PD. and the plastic can either be incinerated as usual in the usual processes, or there is pretty good evidence that it dies on plastic after about 3 days, so you can actually store it externally if you need to. Okay, so we're beginning to move. I've got a few more questions here. Where have I got to? Somebody's mentioned that somebody has seen some PD fluid in one patient in the PD fluid. I've just got a little message from that, so it's not completely and utterly excluded. So going back to catheter insertion, 1 or 2 people have asked about surgical insertion, and quite a few people have mentioned the use of ultrasound during catheter insertion. I was wondering whether you have any comments. Perhaps we could hear from you, Lians, first about that. Do you have any comments there about the way you've been putting your catheters in?
Yeah, I mean, I think either is probably the best thing to do, is whatever your local experience is good at. So in our case, our surgeons place them all around the city, and so our surgeons are most familiar with them. We do have a handful of interventional radiologists willing to do them, and they do them occasionally using ultrasound and fluoro, but it's not commonly done. So in our case, we went with what we knew had the most experience and the most comfort, and it was having our surgeons do it the way they normally do it, using a double cuff catheter, just like they would otherwise in the OR.
I would like to, certainly
yes.
I can think of at least 2 patients we would not have gotten catheters in if I hadn't had the interventional radiologist with me driving the ultrasound, and it meant that when you are burying the needle, because you do have to bury the needle in order to get the catheter in on much larger patients, you can actually see where you're going, and you can have that confidence to continue, because certainly if I had tried to do them without ultrasound, I know that they wouldn't have gotten catheters in. So I do think that, I think basically use whatever you have, and definitely I do feel that there's definitely a role for interventional radiologists in putting in these catheters, seeing how quickly our interventional radiologist Jason has managed to learn to do this. These are skills that are transferable, that they can very quickly review and change in order to put in a PD catheter.
So I guess the general message there is do what you're good at already, and use the skills of the people already got that are transferable, rather than try to do something new in this situation. So whilst I'm thinking about things, are there any comments that the members of the panel would like to draw to people's attention following having had the others speaking?
One of the comments that that some of the intensivists made was that they were concerned about us putting catheters in on patients who were desaturating at that time. So what I have discovered is you can do quite a bit of the procedure without ever having to have the patient completely flat. And at the time that you put the patient completely flat, as you have mentioned, Brett, increasing the PEEP and the oxygen flow at that moment, and having an intensivist with you, which I had for probably 3 of the patients, meant that we were able to actually insert the catheter safely, and then the patient can come back up to 45 degrees in order to have the tunneling done and the completing the procedure and sutures, etc. And so I wouldn't shy away from those patients, but obviously have a plan for how you're going to manage the insertion.
I mean, I've certainly put in a number of catheters in patients who come in with acute pulmonary edema who aren't ventilated, and put the PD catheter in with them sitting upright. So you can do it. Fortunately, it's not like putting in a central line. The air emboli are not a problem.
1 or 2 people have asked about coagulation problems in these patients. Some of them might be anticoagulated or other problems. Have you had difficulties with respect to bleeding? And
So we haven't had any bleeding complications at all. Obviously, it is an issue. You know, a lot of these patients are on even full dose anticoagulation. Sometimes just as we're prophylactically, but sometimes because they're known to have had PEs or whatever. What we will routinely do is if they're on heparin, we'll just stop it for 8 to 12 hours and then go ahead. Certainly I've put in a number of catheters in people with APTTs of 1.5-ish, and they seem to be fine. If the procedure is uncomplicated, patients tend not to bleed. One always worries you're going to hit something intra-abdominally, but so far we haven't in any of these ITU patients.
We've also done the same thing, just kind of held the heparin just for a period of time, the short-acting heparin. And we use heparin 500 to 1,000 units per liter in the dialysate to help prevent any problems with the fluid going in and out, and that has not been an issue whatsoever. If anything, potentially has helped.
I think one of the things, though, if you're putting your first few catheters in, these patients often they often bleed on the skin just as you make the incision. A little bit of local anesthetic with adrenaline in it often cures the nerves rather than anything else.
Yeah, obviously these patients don't really need anesthetic, but I think Elaine, you and I both put anesthetic for the incision with adrenaline, and two reasons for that. One is because the adrenaline stops them from bleeding, and secondly, it's quite nice because it sort of distends the tissues and makes it easier to form the pocket. But I don't use any anesthetic for the tunnel or for the exercise incision.
Another question that has come up is the question of acid base and bicarbonate versus lactate containing solutions. Have you had any difficulty in controlling or problems with lactic? I mean, obviously they may be having lactic acidosis for some other reasons in these patients, but have you got any comments to make on that? And perhaps Brett, you'd like to talk a bit about that because it's a more general question around PD.
Yeah. So Karen, you?
Yeah. Our experience to date has been, it's not really been particularly problematical. We did have one patient who was very, very sick, as I said, and that patient had an elevated lactate, but they were very sick and really in the process of dying. But otherwise, it's not been a big issue. Would you agree with that, Elaine?
Yeah, absolutely. I mean, I suppose we are lucky enough that we can use the bicarbonate fluid, so it's not really been so problematic. And if people are getting these high lactates, it's usually a respiratory issue rather than a renal issue. So no, it really hasn't been a major problem.
Yeah, I think that the bicarbonate-based solutions would be a great option if you have them available. Yeah. But most of the patients on ICU, and especially when it comes to the time that you're going to be filtering them, these patients often their lactic acidosis is a result of hypoperfusion. So hopefully you've corrected most of that, and therefore giving them exogenous lactate, they will be able to convert it to bicarbonate. So it's only going to be in the few patients. In terms of our guidelines, we've recommended a bicarbonate-based solution because there's one randomized trial showing that the pH improved more rapidly if you used a bicarbonate-based solution. But actually, it was marginal, the difference. And also, if the patients didn't have a particularly high lactate at the start, it made absolutely no difference to your acidosis. So I don't think we must shy away from using lactate-containing solutions.
And I think our clinical experience here in New Orleans hasn't been that these patients are severely in shock, the classic shock that we see. They might be on just one inotrope, if any. It's particularly the severe respiratory dysfunction. And so that's usually the major problem. We haven't had any problem as far as the fluids, and we're limited to what we have, which is we use the Baxter Dialysis solutions. That's pretty much all we can use at our institution.
Great, that's very helpful. So are there any other points that people would like to raise from the panel? We're beginning to see a little reduction in the question asking rate, and people are beginning to leave now. Well, we've still got 600 in there. Do you think we've covered everything that you would want to impart in terms of wisdom?
I would just like to raise is we're all learning from this COVID experience. It's made us all change the way that we practice. And do you think that there's going to be a role or a bigger role for PD in ITUs and for management of AKI in the UK, in the US after this? Let's go to the US.
Well, I think, honestly, I hope the answer to that is yes. I think what we've learned is that it's functional, it works well, and we can do it. It's just not something we've commonly done here in the United States. I think after this experience, a lot of the critical care in the hospitals will understand, and the nephrologists will feel more comfortable using this. I do think one of our limiting factors in the United States is simply the notion of how do you transition the AKI patient out of the hospital and into an outpatient dialysis unit. Funding is our major barrier for that. CMS now does cover AKI, but only hemodialysis, not PD. So until that is changed, we're a little bit stuck in our ability to transition patients to the outpatient sector. But I think that this session and the fact that COVID has done what it's done, there are going to be many nephrologists in the United States looking at this as an option after this is all done.
I think the feedback from the nurse teams on ITU are that they actually they love PD, because of course otherwise they will be changing several bags on a CVVHD machine, as well as looking after 4 patients. So yeah, they're very grateful, and they seem to, apart from being a little bit frustrated that they can't put an hourly rate of UF into their chart, they're very, very keen on it. So I really hope so. I hope we do a good enough job that people are more interested in it and want to use it moving forward.
Just the additional thing, so obviously in the UK our funding issues are very different. I think one of the things which may not change is that with CVVHDF, ITUs have got very used to really being in control of the renal failure. So most acute kidney injury, certainly at King's, they don't ask us to see. Most of it's pre-renal. They know what it's due to. They don't require our opinion about the cause, and they will just manage it. And they now, because they can filter patients, they can do that. The question will be with PD, if we start using it in ITU, is will they take over both the catheter insertion and then running the PD completely, so they bypass the nephrologists, or would they, if they were going to do that, use nephrologists? We'd be very happy to be used, but we've been very happy, I suppose, as nephrologists over the past 15 years to allow ITU to just run their own acute kidney injury and not call us in. I don't know, Simon and Edwina, would you agree with that?
Yep.
I certainly would agree with that. I mean, I think, you know, that's been a big change in my career time. You know, I think at the beginning of my career, we all treated all patients with PD for acute kidney injury. That was the routine procedure. Then CVH came along and changed things, and it has been very much, you know, a split of specialties. But I think, you know, we're clearly learning that sometimes you throw away with the baby with the bathwater when you change everything from one thing to another, and that a mixed economy actually may be something we need in the future.
Yeah,
I think if anything, that's something that we should take home from all this. Edwina, you wanted to say something?
No, just that there's going to be another peak in COVID. We heard about that from our team meeting this afternoon, another peak expected for November. So should we be thinking of doing a randomized trial, or actually more formally comparing the outcomes on standard hemodiafiltration compared to PD? We've got time to plan it.
I think that's what we need. You know, most of the places in the world that are doing acute PD are low resource centers. We see great outcomes, but in most cases, you can't actually run a big international trial. And I think until we've got that, we may struggle to convince intensivists around the world that it is a good enough modality of treatment, or as you know, if the Saudi data is correct, it may be even better. So I certainly think it is worthwhile, and we'll have the numbers of patients. And there's enough reason with catheters clotting and with the lack of resources to justify us looking at doing more acute PD.
And certainly no shortage of patients at the moment, and therefore presumably with another peak, no shortage of AKI then either.
Well, that might be on a good moment to finish, something for us all to think about, how we would design such a complicated and difficult trial. I don't think it's trivial, but evidence is evidence. So I think I would like to suggest that we do draw it to a close now. There have been many questions that have been asked by attendees that have not been specifically asked, but my understanding is that we will be going through these and doing some replies, and this whole webinar will be available for people to watch in the future. So it just remains to me to thank very much the speakers, the participants, and the organisers from ISN and ISPD have helped us put this on. And I think the huge attendance of it, we were actually well over the maximum allowed of 1,000 people to attend this. Just shows us all just how much interest there is in this and how important an issue it is. So many thanks indeed to everybody involved, and maybe we should do one again fairly soon. Thank you.
Thanks, Simon.
Thank you.
Thank